Yeah. So thank you, Sanjay, and thank you, organizing committee, for inviting me to give this talk on resistant hypertension. I promise I'll finish in 12 minutes.
Go full screen, sir.
Yeah. So what is resistant hypertension? Unfortunately, hypertension being so common, probably the oldest known disease, but when we search the literature, every time you end up limited information about everything about resistant hypertension. But as far as definition is concerned, in compliant patient who is on lifestyle changes and BP is not on target, despite three drugs, one of them necessarily being a long-acting diuretic at optimal, maximal or maximally tolerated doses. If target is still not achieved, that we call resistant hypertension. We can debate about target, I'll not get into it, 140, 90, 130, 80, depending upon what guidelines you want to follow. How common is this? Again, limited information, depends whether you are seeing in general practitioner point of view, specialist point of view, clinical trials, hypertension clinic, etc. But generally, it is believed that 10 to 20% patients will be difficult to treat or resistant hypertension. Secondary hypertension is when you have a specific treatable cause. It is not synonymous with resistant hypertension. And this is what I mean. If you have hypertensive, some of them will be resistant, some of them will be secondary. If you have a secondary hypertension, unless you treat that cause, it is more likely to be resistant as compared to normal hypertension. Controlled resistant hypertension, when you use fourth drug and blood pressure falls in line, that is called controlled resistant hypertension. Refractory hypertension, when you have to use 5 or more drugs to achieve the target, that is refractory hypertension. Before we call somebody resistant, let's rule out pseudo resistant, and that is the crux of this talk. This is just to emphasize you how many times you can go wrong in measuring blood pressure, right from top to bottom. And a small study showed that those patients who were referred as resistant hypertension, when you measured them carefully in an ideal setting, one third are not resistant hypertensive. Second, rule out white coat hypertension. We all know white coat hypertension, what it is. In a Spanish registry, 8,200 patients, many of them who were referred as resistant hypertension, and when we liberally used ambulatory blood pressure out of the office measurement, one third were not resistant. So that means many of the so-called resistant hypertension, if you evaluate them by ambulatory blood pressure, are actually not resistant hypertension. We all know this. Non-compressible arteries can lead to high systolic blood pressure. And again, it goes, all of us are aware, it is more for systolic hypertension as compared to diastolic hypertension. Non-compliance of the drug treatment. How can you call it resistant when the patient is not taking the drugs? And there are various reasons. In the Western trials, 40 to 50% is the default rate. No lifestyle modification being followed, and that is very common because once the patient start taking the drugs for hypertension, they think lifestyle modification is not so important. He might be taking the drugs, he might be taking the lifestyle modification, but he is taking some of these culprit drugs which is causing hypertension or which is attenuating the antihypertensive effect of these medications. So look into the drug history and find out if he's taking anything. Physician inertia, very important. And that is probably the commonest cause. Patient is coming to you all the time telling high blood pressure, but out of busy schedule or any reason, if you are not able to upgrade the medicine, how will the blood pressure be controlled? Why are we worried about resistant hypertension? Because there is clear data that this is associated with higher occurrence of death, MI, stroke, heart failure, and renal failure. So it is a dangerous disease. It is also known by the company it keeps. It is more common in elderly, obese, diabetic, CKD, those with sleep apnea, those with stroke, MI, etc. And there is a group of researchers who think that resistant hypertension per se, it is not because of the blood pressure, but because of the company it keeps. because it happens in with so many comorbidities which are anyway known to increase cardiovascular mortality and morbidity. Resistant hypertension have more activation of RAS, sympathetic overactivity, MR excess, and vascular stiffness. So many times the treatment also does not lead to exact benefit because there are associated comorbidities. Genetics plays a role. Polygenic, not clearly understood, but genetics is also a factor. Secondary hypertension is a very, very important cause. And many times we get bugged up by secondary hypertension has so many causes, but I can tell you it has got only 8, 9 causes. Renovascular, renoparenchymal, aldosteronism, pheochromocytoma, Cushing's, thyroid, coarctation, Takayasu. And if you remove all them and if you diagnose all them, which is possible, simple, by easily available test, you can rule out 98% of secondary hypertension causes. When you come to the treatment of resistant hypertension, first important is lifestyle modification. This is a group where lifestyle modification is going to be even more important than general hypertension. These patients have volume expansion and salt restriction is all the more important in them. Weight reduction, we will come to that. Adipocytes stimulate aldosterone secretion. Weight reduction is very important. Regular exercise, moderation of alcohol is very important. Diagnosis and treatment of secondary causes, it goes without saying, if somebody has tight renal artery stenosis or Takayasu or any such secondary cause, unless you tackle that, you will not achieve good blood pressure control. A word about sleep apnea. It is a very known combination, deadly combination of obesity and resistant hypertension and OSA. Hyperaldosteronism, fluid and water retention, parapharyngeal edema, more OSA. And if you use CPAP in them more than 8 hours, it leads to reduction in blood pressure. Coming to the drug therapy, first step is triple combo of ACE-ARB with long-acting CCB or a long-acting thiazide type diuretics, chlorthalidone or indapamide preferred over chlorthiazide. It is effective, synergistic, cheap, well tolerated, easily available and proven in large trials. CTD more effective than chlorthiazide. If you are not able to control with this, add aldactone. Aldactone is the cornerstone, MRA is the cornerstone of secondary hypertension or resistant hypertension therapy because 1/3 of patients have some form of hyperaldosteronism. As I said, obesity has a particular association with hyperaldosteronism because adipocytes stimulate aldosterone secretion. And this is a pathway 2 trial, patients on triple therapy and then randomized to aldactone versus bisoprolol versus dilator and found that spironolactone was better. It also showed that we can use higher than 25 milligram doses. We can extrapolate that if aldactone is effective, eplerenone is likely to be effective and will be associated with less gynecomastia and vaginal bleeding. There is a limited evidence that amiloride is also equally effective. The pathway trial also showed a very important concept that it is the excessive fluid retention, which is manifest by high aldosterone and renin ratio. Low renin, high aldosterone ratio, and MR studies and ultrasound studies have also shown fluid retention. So this trial also showed that fluid retention is the basic pathophysiological mechanism. So going further than triple therapy MRA, and after that you need to after that you have many options. You can have beta blocker, you can use centrally mediated arcamine and moxonidine, and you can use various therapies where dilator like hadlazine, minoxidil, alpha blockers also. I want to highlight in one line, there is very limited experience and information about which drug is better or which drug is not so good. It is probably suffering from the because there is no intervention, there is no device, there is no costly things involved. So there are not major trials happening in this field. CKD is also always to be remembered. It is an important cause and it is an important consequence of resistant hypertension. And it is known to lead to expansion of intravascular volume and fluid overload. And also it is it is a known poor predictor of outcome in resistant hypertension. So that is all the time. Whenever you have resistant hypertension, one thing you should investigate, diagnose, and look for is renal parenchymal disease. Just to give one or two examples of secondary causes: fibromuscular dysplasia, young women, you do angioplasty and they respond very well. There is some restenosis, but the response is very good. A word of caution about atherosclerotic renal artery disease. We suffer from oculostenotic reflex. We have hypertension. We have renal artery stenosis. Everybody will put a stent, but there is a very limited data about the usefulness, and it is a grossly overutilized and overused therapy. One has to be very careful. A word about refractory hypertension. When you have to use 5 drugs or more, then it is called refractory hypertension. It is assumed that you have taken care of secondary causes. The difference between resistant and refractory is, in resistant, it is volume expansion. In refractory, volume expansion is usually not there. Either it is not there or it has already been taken care by MRA and diuretics. But these patients as a group have higher heart rate, increased norepinephrine levels, arterial stiffness, signifying increased sympathetic overactivity. And in this situation, centrally acting drug like curcumin and clonidine and moxonidine are especially helpful. A word about renal denervation. Simplicity 1 and Simplicity 2, both trials were done to see its usefulness in refractory hypertension. 1 and 2 both show positive results, and the 3 trial which compared sham procedure versus renal artery denervation unfortunately did not show a positive outcome. There was 14 millimeter systolic reduction with RDN and 11.7 millimeter reduction with sham procedure, which was not statistically significant. But this concept does not still holds promise, and it is possible that we are doing some mistake the way we are doing RDN, because a very recent and beautiful work by Garcia et al. Has shown that
Rajeev, time's up.
just 1 minute, because it has been shown that most of the sympathetic nerves are not hanging around hilum. So you have to do central as well as more peripheral ablation. And there is a concept of LAN, late arising nerve, and very late arising nerve, meaning thereby that we have to modify the ablation procedure and it can be effective. Chronic baroreceptor stimulation by an implantable device has been evaluated, found to be useful, associated with some side effects, is still not available for chronic use. So dear friends, resistant hypertension, whenever you think of this problem, think of 4 or 5 things. Number 1, rule out pseudo-resistant. 40% will be pseudo-resistance. Rule out and treat secondary causes. Many will go away. Lifestyle modification remains very, very important. Triple therapy to begin with, then add MR antagonist, then add beta blocker, and then it is free for all, whatever you have according to the comorbidities. RDN and RDN can be a therapy in future. It still holds some promise, and carotid sinus stimulation is still at the experimental stage. Thank you very much.
Thank you, Rajeev. I think it was a big topic covered in a very short span of time. The message was loud and clear. To diagnose resistant hypertension, we have to be sure that the person is compliant with the diet as well as the medicines he's been taken. The drugs are properly dosed, and the diuretic has to be in a proper dose there without a fluid overload situation there. And also exclude elderly people, especially with calcified artery. Very important to understand that there are symptoms of hypotension and the pressures are high, then we should count them out. Thank you, Dr. Rajeev. I think in the interest of time, I'll call the session at close.